Thank you very much for this occasion. I thank the organizer of this meeting that have invited me to present to you our experience as Rwanda. I have nothing to disclosure. This is the outline of my presentation. Starting by Rwanda background, it is a country situated in the Eastern African with a population of 13 million, capital Kigali, with GDP of 702 US dollars. It's situated in the low income level. And the prevalence of HIV is 2.8% according to data of 2019. And the people living with HIV is about 200,000 people. And the burden of viral hepatitis is estimated at 3% now. This is the journey toward viral hepatitis elimination, which was planned to be done in 2024. And from 2011 up to now, in the creation of hepatitis program in Rwanda, a lot has been done, starting with the creation of this one. And then we developed a national technical working group, developed the national policy, national operation plan, and the different people have put on treatment for hepatitis C, even on hepatitis B treatment. We screened about more than 1 million of people, and we introduced rapid testing, the rapid test in our screening test. And up to now, 15,000 people have been treated for hepatitis C, and more than 1,800 people are on treatment for hepatitis B. This was in 2018 where we launched the elimination plan in Rwanda. You see the minister and the global chair was opening the plan here. This is the geographic variation in the proportion of hepatitis C surface antigen positive in the whole country. You see that in the eastern province we have high positivity of hepatitis B, and even in the north. This is the seroprevalence of hepatitis B among different people, different group of people, so that according to age, the high prevalence of hepatitis C is between the age of 25 years to 44 years old in the age group. This is risk factors for hepatitis B in Rwanda, where we have social demographic characteristics like gender, geographic variation, marital status, comorbidity also. We have other also risk factors like history of surgical operation, history of traditional operation practice disqualification, and also history of viral hepatitis in the family. This suggests here the horizontal and the vertical transmission of hepatitis B in Rwanda. This is the cascade of care for hepatitis in Rwanda, where we have two cohorts, one 2018 and another in 2019. In 2019, we saw that we screened about 400,000 people, and the same number in 2019, where we have in the 2018 3.2% positivity, while in 2019 2.3%. The difference is because in 2018 we started screening with the age of 25 years old, while in 2019 we started elimination with age of 15 years and above. And we have people on treatment about 1,800, and cirrhosis due to hepatitis B 288 in 2018, while in 2019 it was 72. Death due to hepatitis B cirrhosis 22 in 2018, while in 2019 it was 21. while hepatocellular carcinoma due to hepatitis B, it was 34, while in 2019 it was 38. And death due to HCC caused by hepatitis B in 2018 it was 13, while in 2019 it was 10. In Rwanda, people are aware, and we have high demand for hepatitis services. As you see, the picture. This it was in 2016. This it was in 2017. In one district, and this it was for the whole country. Means that the demand increased and the awareness increased in our population. As a national response, we have availability access to viral hepatitis services as follows. We have ELISA test site, which is L15. We have a viral testing site, 9, which are doing testing hepatitis B, hepatitis C, and also HIV. We have laboratory technicians who have been trained on hepatitis testing. You have prescribers, about 300, which include nurses, GPs and the specialists. We have pharmacists who have been trained also. We have nurses around the country in health centers who can do sensitization, who can do also follow-up of patient on treatment. This is the distribution of different platforms of testing in our country, where for ELISA, we have 9 sites, as I said before. We have also distribution of viral platform around the country. We have also Gene Expert platform, which can help us also in viral load testing, but we're still negotiating with them in order to have the acceptable price in order to include them. We started also to use rapid test in our health facility. We started with district hospital, but we increase the use of them in the health centers. This is the pyramid of our system, our health system in Rwanda, and these help us in also dealing with hepatitis management. We have started by the community health, where we have community health workers who and the health post who are helping us, who are helping in the sensitization, while from health center up to the hospital, they are doing screening. They can do confirmation, they can do treatment initiation, counseling, and sometimes, if needed, transfer to other level. That's this distribution of health facility in our country. As you see in the red, the health centers. We have the street hospitals, we have provincial hospital, and the referral hospitals. Rwanda has developed a target screening strategy in order to simplify something about the services that are being given to a population about hepatitis. As you see, we started a screening in 2016, where we targeted key population, people living with HIV. After that, in 2017, we screened all prisoners and the people over 45 years old, as this has been identified as a high-risk population to get hepatitis C before. In 2018, we started screening in specific geographies according to what we had before for people, for different regions who had a high prevalence of hepatitis C. And after we started with the first of elimination in 2015, starting with 15 years old for all people. As a result, we have data that can be data being used to advocate for elimination agenda. And we started also treatment for 13,000 people for hepatitis C, and more than 1,800 people for hepatitis B. This is about the centralization task shifting. In 2016, we had only 20 prescribers who were specialists in 10 hospitals, and now we have about 310 healthcare providers, which include doctors and nurses, who were trained to support prescription of hepatitis drugs. These include nurses, we have GP and a specialist. This is algorithm, a simplified algorithm for hepatitis screening, diagnostic and treatment for hepatitis B, where we started by RDTs or ELISA. A person who becomes positive is evaluated for to be put on treatment, maybe using clinical exam or APRI score, or we can do, we offer to all, we offer also HBV DNA, which is free of charge for all populations. And the criteria for starting treatment is cirrhosis, the presence of cirrhosis, APRI score, which is more than 2, DNA HBV, which is more than 20,000 international unity per milliliter, and also alert, which is abnormal. This is option of treatment for hepatitis B in Rwanda, where for people over 12 years old, we offer tenofovir, and for people children between 2 and 11 years old, we offer entecavir to them. We have challenges. As you know, treatment for hepatitis B is for long. It's a long-term. It's a long-term treatment. For that, follow-up. Doing follow-up is difficult. We have multiple loss to follow-up due to that, and also delay in HBV DNA delivery, because it's being done in 9 sites only. It would be better if we should have in all districts platform for hepatitis viral load. As we are using rapid test, and some rapid tests have specificity which is low, maybe we should have false negative, many false negative. And also we have limited laboratory equipment, as we do not have in the public hospitals platform that can test HBA antigen, and we can treat some people who are not eligible to treatment. Way forward, we are going to use RDTs for hepatitis B in the HCV and oral health facility, including health centers, increase the number of sites equipped with hepatitis B and hepatitis C viral load platform. We are going to continue capacity building in order to integrate all in the oral health facilities. We are going to treat patients diagnosed and eligible to HBV treatment. We are going to strengthen monitoring and evaluation. We need to do now we are thinking to do the national data set for hepatitis B and hepatitis C, which will be included in the health management system, and then it will help us in the controlling the hepatitis, who will be screened, who will not be screened, who have been screened before, and so on. And also, we are going to do more researches on viral hepatitis and the scale-up implementation of viral hepatitis elimination, which started in 2018. As a lesson learned, we saw that decentralization and integration of viral hepatitis management is possible, including task shifting to nurses at health centers. Testing using RDTs should be done at lower level, health center and district hospitals. Using generic drugs increased access to treatment for all people. I would like to thank all the contribution to the program, to our program, including government of Rwanda and other colleagues who contributed to this. Thank you very much for your kind attention.